Welcome to Radio CAHS, presented by CAHS Chief Executive Dr Aresh Anwar.
Welcome to Radio CAHS.
Hi everyone, I'm Katie McKenzie. I'm the Executive Director of Nursing and the Executive Lead of CAMS and Community Health Services for CAHS. So obviously I'm not Dr Aresh Anwar, but I'm super excited and super nervous about doing Radio CAHS today. So I'd like to start by acknowledging the traditional custodians of the land, the Noongar Whadjuk people, and the Aboriginal people of the many traditional lands and language groups of Western Australia. I would like to pay my respect to their elders past, present and emerging. So today's show, jam-packed, super exciting. We've got Dr Dan with us for a COVID update, and we have Julian James, the Manager of Training and Education for CAMS, and Chelsea Catchpole, who's the Staff Development Educator on Ward 5A. Now today's show, after Dr Dan, is about Mental Health Week. Mental Health Week is next week, and the theme is strengthening our community, live, learn, work and play. And the aim is to increase mental health wellbeing in WA communities. So for CAHS, that means we have a dual focus, where we have a role in the mental health and wellbeing of children and young people, and also our staff. So, Dr Dan, COVID, mental health, over to you.
Thanks, Katie. I guess what I wanted to talk a little bit about today is some work that's been done locally, and I think probably linking to mental health actually in WA, what we found initially with all the lockdown was actually there was an impact on, I guess, our admissions, and what that looked like in mental health was that there was an increase actually in our young people presenting with eating disorders, and that's work that's been led by the Eating Disorders Adolescent team. Andrew Martin, I think, was involved in that as well. I guess what I'm slightly more familiar with is, I guess, that we've had a reduction in admissions related to respiratory viruses, and I guess it's probably a positive spin, in addition to the fact that WA has done relatively well and I guess been lucky in not having a lot of community transmission with COVID. What we've found and what we've looked at, along with the PathWest team who look at sort of surveillance of respiratory viruses, and the team from Telethon, is looking at really how that sort of change in behaviour initially, and importantly the closure of borders has impacted other respiratory viruses. So really what we found this year is that sort of influenza and RSV, which are both very important viruses for children and lead to a lot of admissions, ICU admissions, a lot of children being unwell, really have essentially disappeared this year, which has been a real sort of, I guess, positive collateral damage from what's happening. Because usually during winter we do see this sort of spike, and sort of several hundreds of cases will end up sort of being admitted to PCH and other sort of, I guess, paediatric wards around the metropolitan area and regional centres. But this year we really haven't seen this happen.
Yeah, and I think, I think it has been a year of duality, hasn't it? For each thing that we think about COVID, there's another side of it. And you're right. So the decrease in respiratory illnesses probably has taken us all a bit off step. We didn't realise that we were going to have quite such a respiratory quiet winter. But equally, there's some children and young people that are not doing so well in this time. So we've had a really busy winter in other areas. So, I mean, I don't know about you, Dan, but I feel the same myself. I feel lucky to be in WA, lucky that we've got our borders closed, lucky that we're safe. But equally, I feel I've got a son in Melbourne and a partner in Canberra, so I'm a bit sad about not seeing them too. So it's, two sides of the coin for each step we take for COVID, isn't it? Yeah,
absolutely. And I think sort of you're absolutely right that we're very lucky here in WA, but that doesn't mean we're sort of an island of ourselves. And we do look to our colleagues over in Melbourne particularly, and sort of, I guess, how they've suffered, and a lot of them have their children and children more broadly at home who've not really been at school for 6 months, and I've got a couple of good school friends over there, and it's really challenging, sort of, and I think that's not a unique experience for the people that we know there, and certainly I think the impact somewhere like Victoria would be much greater in terms of sort of mental health. And we've spoken previously about this, I guess, that a lot of young people do access sort of mental health services through school, but there's also the socialisation and sort of that structure that it provides, and again, we're very lucky over here that we've had schools sort of go back since April, and really, I mean, that's the other surprising thing looking at respiratory viruses in WA, is that usually these things that sort of spread through schools, children are snotty, they bring the viruses home. But even after we've opened schools here in WA, we really haven't seen these things take off. And in fact, sort of we're almost at single-digit detections in metropolitan children. And I think that really suggests that sort of we've been protected by closing our borders. And I guess what will be challenging, and I will talk more about this, I guess, as we enter next year, is that probably with less people having had influenza, particularly this year, that when we do reopen borders, be it next year or the year after, and we allow people to come in again, that there's probably less people with sort of immunity to influenza, so things like the flu vaccine will be of increased importance in future seasons, because we're probably more susceptible, having had a relatively easy year this year.
Yeah, it is something that's keeping us on our toes constantly, isn't it? Now, I'm scared of needles. I do have my flu vaccine, but I hate it. So tell me, how far away do you think the vaccine is?
For COVID,
Yeah.
I think it's been, I guess, interesting watching the data come out, and there's been a couple of groups in Australia, sort of Katie Flanagan in Tasmania has put together a really nice paper, and I think sort of we spoke again about this previously when the first data came out about the RNA vaccines, and looked quite promising. But I think that's been tempered somewhat, I guess, by the challenges. You might have heard the Oxford trial had to be put on hold because there were some side effects. It's back running now. And I think sort of as we've understood more about the immunity that you require for sort of, I guess, prevention of transmission, that I think the immunologists that sort of that are talking about this are saying don't be too hopeful that the first vaccines will be absolutely effective. I guess talking again about the influenza vaccine, obviously we give the flu vaccine, and even if we were to give it to 100% of people, probably there'd still be some people who get influenza, probably less severely than they would have otherwise, but it's not enough to eliminate transmission, even if sort of everyone took it up, because the vaccine's not quite perfect. And that's more to do with flu changing with time. But in the same way, the COVID vaccines, which will come out initially, I think we're anticipating that they may not be perfect in preventing infection, absolutely. They'll obviously provide some level of protection and probably reduce transmission to some degree. But I think the idea that we'll have a vaccine and I guess we'll be able to give it to everybody and then we'll be able to go back to normal is probably, I guess, a little bit too hopeful. Probably it'll be more gradual, and certainly there's so many vaccines in sort of development that it may be that some of the later ones are more effective, or that sort of a combination of two with a booster dose here or there may be effective in limiting transmission so we can open up a bit more. But I think certainly sort of the initial ones, we shouldn't be too hopeful that there'll be a magic shot and we'll be able to live back to normal again. So, and I guess there's the other challenges as well. Essentially, if we're talking about international travel, to open up the borders, you need to get sort of billions of doses into everyone around the world, and that's got its own challenges beyond sort of convincing people that they should be getting the vaccine. So
yeah. Oh, well, fantastic. Thanks so much, Dan.
no worries at all.
Questions, apparently. Okay, apologies about this. DJ Houston's actually going to sack me on my very first go of Radio CAHS. Okay, I'm going to... okay, sorry, DJ Houston. I am going to pass over to Beck, who's got some questions for you, Dr. Dan.
I do have some questions for you, Dan. Are you ready?
Yeah, sure. Go ahead, Beck. Yeah.
Can you get COVID through your eyes? And should we be also wearing goggles?
So I guess it's a good question, and again, we're learning more and more about this. And I think what's come out most recently is that in terms of transmission, that the major mode of transmission is by breathing in sort of, I guess, infected particles. And so sort of things like masking in the community where there's high prevalence to prevent you from putting out these infectious particles, and also I guess sort of wearing appropriate PPE sort of in the hospital setting when you're taking care of a patient with COVID is sort of focused on sort of masks essentially. And I think sort of the touching surfaces as well as sort of, I guess, contaminated surfaces seems to be sort of a less important mode of transmission. But certainly we know that sort of hand hygiene can sort of, I guess, kill this virus and is very important. And sort of contact precautions are also sort of recommended, gloves and gown. And I think as part of that, sort of also if you were to touch your eye and there's sort of mucosa there which might be susceptible to infection, it's not really been sort of, I guess, a major thing that's been coming out to say that that's an important way of things being transmitted, but I think it would be sensible to do that, yeah.
I have another question for you.
Yeah, go ahead.
Should we wear face shields instead of, or in addition to, face masks?
And again, I think, apologies, Beck, I'm not quite sort of absolutely across this, but my understanding is face shields are to sort of protect the direct sort of transmission of sort of droplets or someone coughing straight into your face. And in the same way, they've been proposed as sort of a way of maybe preventing people from breathing out infectious droplets. I think sort of what's coming out is that masks are probably the most effective way of sort of doing that. And so that's probably what we're going to focus on, sort of more than face shields. And I guess it's what we've been accessing and stockpiling here is sort of masks as well as, I guess, eye protection. Yeah.
Great. Thanks so much, Dan. Apologies, DJ Houston and Beck, for my less than smooth transition. Dan, it's always fantastic to talk to you. I love learning from what you know. So thanks so much for that.
Appreciate it, Katie.
Welcome to Radio CAHS, presented by CAHS Chief Executive Dr Aresh Anwar.
Welcome to Radio CAHS.
Okay, so we now move on to our theme of Mental Health Week, and to help us discuss this, we've got Julian James and Chelsea Catchpole with us. Now, as you all know, I'm new to my exec lead role of CAMS. As it stands, Julian and Chelsea, you are my two favourite CAMS staff, but as I meet more CAMS staff, I'm sorry, it's always open. So, today we're going to be talking about vicarious trauma and what we're doing to support our staff who may be experiencing vicarious trauma. So, Julian, I'm going to start with you. How about you tell us what your role is at CAMS and how you came to work in education and training?
My role on CAMS is as an education trainer. I started off being a clinician, and then I moved into education and training because I became very interested in therapeutic crisis intervention. And that is a really good model for working with young people in crisis, so I decided that would be a great way to expand in our service, in mental health particularly, but it has great opportunities for all services. So that's why I ended up in education training. I just love training, I love educating people. I love reading about new ways of doing things, the research and the way we can change the way we work with young people. So I always find I like to share that knowledge with other people as well.
Great, and I know, having seen the broader introduction of TCI, therapeutic crisis intervention training, to staff outside of our Ward 5A, look, this is one of the main ways that we can equip staff to be resilient about what they deal with in the workplace. So you've done an amazing job with that. Well done.
Thank you.
So tell us, vicarious trauma is probably a word that we do throw around a bit, but you are an expert. So tell us, what does it actually mean in the context of staff and in the context of working in the environment that we work in?
Well, vicarious trauma is that trauma that you get from watching and observing and being part of working with other people who are going through their own trauma. So in our environment, where we have a lot of people who work in health because they want to care for people and they're compassionate, they have a lot of empathy, it's a great way for us to support our staff by recognising that when people are getting very stressed or anxious from working with young people in very stressful situations, not everybody's going to get vicarious trauma. It's not. It depends on your own personality and your development. Some people can go 20, 30 years without developing any vicarious trauma, and yet some people can come out immediately and get exposed to some trauma, and then it becomes very overwhelming for them. So it's insidious. It can grow over time. It's not naturally knowable at the same time. Because it's insidious, we don't often recognise it's creeping up on us. And sometimes it doesn't happen until we have another traumatic event, and that really puts a spanner in the works, and we find that we're struggling with anxiety, we're struggling with sleep, and we're becoming somewhat depressed. We don't have the same appetite, we don't have the same enjoyment for life as we used to. And it can often be traced back to lots of experiences of trauma, which we call vicarious trauma.
Yeah. Now, of course, because I am who I am, and you wouldn't expect anything less, I've got loads of questions for you. So, I've been a nurse for 22 years. Back in the early days, it was just like sit in the tea room, chat it out, make a joke, say something, black humour kind of thing. Basically, it was a grin and bear it kind of attitude.
Yeah.
So, the recognition of vicarious trauma in a work environment, is that a newer phenomenon, or is it something that's always known, we just hadn't really engaged with it as well as what we should have?
I don't think it's always been known. Trauma, particularly psychological, emotional trauma, which is what we're talking about, not the physical trauma or sexual abuse, that kind of trauma. The emotional or psychological trauma, the research around it is becoming much clearer now about how it can be so debilitating on people if they experience trauma and don't get treatment for it. So we know that well from working with children. But what we're discovering with adults is that when you're exposed to trauma over a long period of time, it can become very debilitating to you as a person. Everybody has their own level of capacity and ability to deal with that. The black humour stuff is great. We used to use that all the time. I mean, some people would go, well, it's kind of inappropriate, but it is a way of helping us cope with the trauma and not feeling so overwhelmed by it. And as a nurse and using black humour myself, it does help. It helps a lot. But there's sometimes it gets to a point where just black humour isn't going to cut it. And you do need to think about, what am I going to do because I'm feeling like I don't want to come to work anymore, or if I have another kid who does this to me, I'm not sure how I can cope with it. They're the clinical signs that you need to start thinking about getting some help.
Okay, well that leads me right to my next two questions. So if you yourself are feeling like that about coming to work, where you just can't manage it, you can't put yourself in one more situation with one more angry child, what do you do about that yourself?
Well, first of all, I'd congratulate yourself on recognising that, because part of the journey on dealing with trauma is recognising you feel like that and saying, this is really affecting me and I'm not sure I can keep doing this. Once you recognise that and go, well, okay, I need to go and see somebody and talk to somebody who can do that. Go and see a therapist, or go and see a counsellor or a psychologist, and start talking about the impact that's having on your life. Trauma can be dealt with quite effectively by being able to talk to somebody. We really recommend that you should be seeing somebody monthly. Whether you're traumatised or not, you need good clinical supervision, and that's not the same supervision you get on the ward, but that's seeing somebody external to your work environment who you can talk to about these things and help process them and put them into some meaningful way for yourself.
Great, thanks. I'm going to save my third question for Chelsea. I don't want to waste all of them. Chelsea will think she's missing out then. So, Chelsea, you are working on Ward 5A. You're also an educator. So tell us what led you to get into your role?
So, thank you, Katie, for saving that question for me. So, yes, I'm lucky enough that I work as an educator on Ward 5A. I've been working as an educator for probably 2 years, but previous to that was working clinically out on the floor with young people who were struggling in moments of crisis. And so obviously doing my best to support those young people, but their families as well. And I suppose that passion to improve outcomes and really provide excellent care to these young people and families who really were at times in their worst moments, in these real crisis points, and needing that support. I suppose that passion has led me into an educator role where I suppose I'm lucky enough that I get to teach and support staff now, not only young people and families, but staff as well, and an amazing bunch of staff that work in the inpatient unit.
Yeah, I agree, Chelsea. Now, Julian took us through what you should do yourself if you're feeling not quite right about coming to work.
Yeah, absolutely.
Now, Chelsea, I know in your role that you do this, and I know this is actually your particularly special skill. But for the rest of us who are not as skilled as you, what do you do if you recognise your colleague is not doing as well at work as what you think they should be?
And I think that's a really, really good question. Julian certainly has given us the information of being able to recognise when, as ourselves, we might need to look at our own self-care, be able to recognise the signs and symptoms of compassion fatigue, vicarious trauma and potential burnout. But I suppose importantly being able to recognise in our colleagues when they're struggling. So there are certainly initiatives within this organisation that we would encourage people who are struggling to actually access. So I know that there are 2 employee assistant programs here that the healthcare organisation offers. So there's LifeWorks and Converge, and every employee here can access those. Those are 5 free counselling sessions that they can access. So certainly by encouraging our employees to use those services, having a look at the space now in that health and wellbeing. I'm so excited, I have to say, the fact that we have a health and wellbeing coordinator, the fact that we have leadership positions in people, capability and culture, and this real drive for more to be able to direct staff to. So certainly we do have the EAP, but there are other initiatives that are really exciting that I think as an organisation we really are recognising how frontline staff throughout this hospital, throughout the whole organisation, be it within this hospital, be it within the community in the CAHS space, we are dealing with some really severe traumatic incidents, some real pretty full-on experiences. And I have to really second the words of Dr. Simon Wood in his newsletter today, where he said, we've got the most amazing, awesome staff who, as Julian said, are compassionate. They come here because they care so much. They want to improve these outcomes for young people. They're not invincible. And so we do need support strategies to be able to support staff who are doing such an outstanding job at improving those outcomes for the sickest kids in the state.
Yeah, thanks, Chelsea. That was a great answer. So what you're basically saying is that we've got to be well ourselves to work with children to be well. Is that sort of it in a nutshell?
I suppose that's it. You can't pour from an empty cup, can you? That's how the saying goes. You do need to be able to look after ourselves. I do think that's a two-way street. We ourselves as employees have some responsibility to look after ourselves, but I do feel that as an organisation, putting those strategies in place to support our staff is really positive, and I'm looking forward to seeing where as an organisation we go with that.
Now, I'm going to ask you to follow on from that. So, Chelsea and then Julian, 2 things that you would like to tell me and the CAHS exec that we need to do in this space.
Oh.
See, lucky I didn't.
Okay, I'm glad we didn't get this question before.
Lucky
Look,
I only said
I
2
think
and not 5.
I don't know whether I got 2 questions, but I do believe that the shape of our future is really an important project that we're doing. We're looking at, improving the culture of the organisation, and the compassion and the accountability and the equity and all those, values that we have. We need to start focusing on each other and caring for each other. We can't do this job on our own. We need the support of our colleagues. And it's not a fault by anybody who gets vicarious trauma. There's not a reason to be blamed or shamed by that. It's because we're compassionate, because we care, we're more susceptible to it. And we shouldn't see that as a negative. We should see that as a positive in some ways, that we care so much, we really feel for our young people that we care for. And to acknowledge that, sometimes I care so much it hurts. It hurts emotionally, and that's okay. And we sometimes I can deal with it, and sometimes I can't. And when I can't, I'll go and talk to a mate, or I'll go catch up with some friends, or I'll go and see somebody about it.
Yeah. Okay, thank you. Caring for each other. And Chelsea, what can we do? What more? Give me 2 things.
Okay, so as I said, I already think to be honest, the fact that we're having this conversation right here, right now, I think is an amazing start. I think to recognise the fact that people are impacted by the work that they do, the families and the young people that we interact with, that it does sometimes, it certainly can affect us. So I'm really excited that we're having these conversations. I do believe, I suppose, as an organisation, and I'm going to just put it right out there, but quarantining supervision for staff, really looking at the importance of, providing debrief spaces that are non-judgmental, that, I suppose a reflective space for people just to be able to look at the work they're doing and be curious about their response to that. Looking at our post-crisis incident support for staff, are certainly areas that I would ask our leadership team, our executive team, to be able to talk with staff as well. Ask more staff as well what they would want. But certainly, quarantine supervision time I feel would be really important, and that real focus on post-crisis incident. Supporting our staff, following those code blacks, those code blues, but checking in.
Okay, Chelsea and Julian, my two favourite people. Questions asked, noted. I'm going to come back to you with some answers about what we're doing in those spaces.
Yeah.
Call now on 6456 5629 or 0436 595 600 to ask a question.
Thank you, DJ Houston. So now that I've gone a bit rogue and a bit off script, I'm going to circle back and give everybody the news. So at CAHS this week, the stars of CAHS nominees for Q3 have been released. Congratulations to everyone who is on that bumper list who has received a nomination. Your colleagues think you are a star. So please get on and have a look on Health Point for the full details of the long list. Now, Monday's a really exciting day for CAHS. We welcome Mel Robinson, who has been permanently appointed to the Director of Aboriginal Health. A lot of people will know Mel. She's worked here previously. She's a real leader in this space of healthcare delivery to Aboriginal people. She's worked in Canberra, she's worked in WA, and I personally am super excited to welcome Mel back to CAHS from Monday. So look out for her, welcome her, and let's work together to see what we can do at CAHS for reconciliation for Aboriginal children and families. Coming up in the next week, we've got some really exciting developments about COVID education, so keep an eye out on the COVID page. We're also going to touch base with managers and educators to start our new risk-based assessment to COVID education. It's going to be about you identifying your own risk and then how we can support training to deal with that risk. So it's really exciting. It's actually a WA health system first to take that approach. Eyes out. It'll be on Health Point next week. Now, finally, applications for ideas for the Innovation Challenge close next Friday, the 16th of October. Shortlisted entries will pitch their ideas, this sounds a little bit frightening actually, to the CAHS Innovation Shark Tank. I look forward to hearing about that. More details about this challenge are on Health Point. Now, Beck tells me there are no more questions for today, so I'm going to draw today's session to a close. I would like to thank Dr. Dan. Thank you so much for coming in and sharing your knowledge with us. Julian and Chelsea, as always, you two are amazing. I'm going to say to everybody, reach out, ask how you're doing, connect as a team, and let's see where we can take it from here once we've got those basics in place. The podcast recording will be sent out to all staff on Monday along with any show notes. So apparently it is at this stage I say Aresh's words of thanks for listening and stay safe, and that's a wrap for today. Thank you.
Welcome to Radio CAHS, presented by CAHS Chief Executive Dr Aresh Anwar.
Welcome to Radio